A healthier, happier life begins here. Welcome to Mercy Moments, a podcast by Mercy Health in association with True Chat.
On the agenda today is mammography and why women are getting or not getting them. With me today is Dr. Deepika Patel. Welcome, Dr. Patel.
Thank you. Pleasure to be here.
Also on the program today is Kathy McCarthy. Kathy is a supervisor of mammography at Mercy Health Urbana and Springfield Regional Hospital. Welcome, Kathy.
Thank you, Terry. Pleasure to be here.
So the first thing on our agenda today is we're going to talk a little bit about what is a mammogram. Kathy, can you answer that for us?
So a mammogram is a special type of imaging exam specific for the breast tissue. The machines are specific to the breast tissue. And we usually do 2 images of each breast and give those to the radiologist to take a look at.
So, Dr. Patel, what are the benefits of a regular mammogram?
The biggest benefit and the biggest reason we promote screening mammograms is to reduce the deaths caused by breast cancer. It's been shown to significantly reduce mortality from breast cancer for those women who undergo routine screening. We often pick up breast cancer earlier when a treatment's more effective and less harmful to the patient. The other reason to get mammograms is because majority of women, we're talking close to 75%, don't have any identifiable risk factors. So it's not just for those patients who have high risk factors or are at risk, because in that case, we'd miss many breast cancers.
So we hear a lot about the differences between 2D mammography and 3D mammography. Can you talk about that a little bit?
2D mammography takes basically 2-dimensional images of the breast, one from the top and one from the side. Over the last few years, we've switched over to 3D mammography, which takes multiple sequences through the breast. There's no real change in the positioning of the patient when we do from 3D mammography to the traditional 2D mammography. The patient is in compression a little bit longer, but basically we're taking slices through the breast tissue, similar to that of a CAT scan. And then the radiologist can scroll through these images and looking at multiple layers of the breast instead of just a static 2D image. The 3D mammograms have been shown to decrease the number of callbacks patient gets. We are able to see smaller cancers just because of how thin those slices can be.
So Kathy, what are Mercy's current capabilities as far as 3D goes?
So at Springfield and Urbana and on our mobile unit, all of our capabilities, we can do 2D or 3D. We currently give the patient a choice, which one they would like. We encourage 3D for anyone that their insurance covers it or they're willing to pay if they don't, because we do feel there's a lot more information that is gained and it's much more helpful for the patient, for the doctors reading the exams. But all of our sites are capable of either, and we will give you the choice currently when you come in.
So that's a good point, that both the mobile and our freestanding facilities all have 3D capability, correct?
Correct.
So one question that women often have is, should I get mammograms if I have implants?
Yes, they should. We have special images that we take. So for someone that has implants, we're going to do the normal routine views that we do on every patient. Mm-hmm. And then depending on how much breast tissue is in front of that implant, we do special views. We call them displaced views, and we try to move as much breast tissue in front of the implant as we can so we can get compression on that tissue. We can do them. We do see there are patients that have implants behind the muscle, and it's much easier to get images and see all of the tissue or the majority of the tissue. For those patients that have them in front of the muscle, which tends to be if you've had them a long time, it's a little bit more work to get those images, but we still can get information that's good. And it's important also to let the technologist know when you have the mammogram, if you have implants, to let us know how long you've had those implants in, because the older the implant is, we want to be a little more gentle with what we're doing because of the age of the implant.
So that's a good point. So does 3D play into that at all as far as where the breast implant is located, Dr. Patel?
As far as where the implant is located?
Right.
Probably not, but 3D is still a good way to go. It's still offered to patients with implants. The other thing I was going to add with the breast implants, it is a relatively safe procedure to do if you're worried about rupture. And that's part of the reason Kathy was talking about how much care they would take in doing the compression. But it is a very relatively safe procedure to do. Right. It doesn't preclude you from getting a mammogram. But yes, you can absolutely do a 2D or a 3D. I've seen both done at our facility. So
Kathy, why aren't mammograms normally performed on women under the age of 40?
We follow national guidelines, and those guidelines, you kind of have to have a starting point. The younger a woman is, the more dense their breasts can be. And it's harder to see things in that dense tissue. So 30 is kind of the age between 30 and 40. They're often, depending on family history, other risk factors may put somebody in below 40, but for the most part, nationally, it's at 40 and above. The American College of Radiology recommends yearly mammograms beginning at age 40.
That's actually a good point, because women often ask, should I get regular mammograms? Dr. Patel? And
I would say yes to that. And to go on Kathy's point too, yes, the American College of Radiology, and as well as several other medical colleges out there, still recommend starting annual mammograms at the age of 40. Depending on family risk, like you stated, we're talking immediate family, first degree relatives, you might be able to go younger than that. But if you have breast symptoms like a palpable lump, between 30 and 40, you can still come in and get a mammogram. Under the age of 30, we kind of go first to ultrasound, just the recommended view to evaluate for any sort of symptoms. And that's just more of a benefit versus risk ratio. As far as getting your mammogram at the age of 40, I think that age was set because there's essentially a big risk increased risk once you turn the age of 40 for risk of breast cancer compared to when you're in your late 30s. It almost doubles, I believe, from what I've read. That risk, the moment you turn into your early 40s, that risk can double. And that's kind of where that line is set. Mm-hmm. The reason to start getting your screening mammograms in 40, it's been shown to, you have the highest, essentially a lot more mortality in that age range, that decade as well. So if you catch them early enough in that decade, you have a lot of more preventable loss.
I think you mentioned ultrasound. What other technologies are out there besides 2D and 3D mammograms? So
we have breast ultrasound, which normally we use as an additional tool following the initial screening mammogram. A lot of patients, if we see something new, they'll get called back for ultrasound. Ultrasound is usually used as an adjunct to mammography. If somebody has an abnormality seen on the screening mammogram, they'll often come back for additional mammogram images or possibly an ultrasound. So that's often when we use it. Breast screening has also utilized breast ultrasound for a screening mechanism. It's usually used in patients with dense breast tissue. However, there's still some investigation as to how beneficial that is for the patient to undergo breast ultrasound. But there is some data out there that it can be helpful in detecting cancers. It may also increase your callback rate. But to answer your other questions, there's also a breast MRI that's utilized, especially in patients with high risk, especially, BRCA genes, immediate family members, anybody who's considered high risk, they often get screening with MRI and coinciding with their annual mammogram, which has been useful. And if there's an abnormality on that, they'll often come back for an additional mammogram or ultrasound to work up those abnormalities. There's been some other imaging, nuclear medicine imaging that's been out there. It's just nothing has come to the mainstream.
I see.
As much as mammogram has. We've had it for so long, and there's a lot of good data as to how useful it can be.
So there's no other technologies out there besides MR ultrasound and conventional mammo on the horizon right now?
Besides nuclear medicine imaging, that might be the only one, but that also has more radiation when you're talking in comparison to mammogram. So it's not going to come mainstream anytime soon, I feel like, because of that. So
the last step in this process after the screenings and the diagnostic exams is the interventional part. Can you explain that just a little bit?
Sure. If a woman or a male comes in with an abnormality, whether it's a screening mammogram or a diagnostic mammogram, which I think we can go into in a little bit, we work it up with an ultrasound. Depending on what we see the abnormality on, if we see it under mammogram or under ultrasound, we'll kind of take it a couple different ways. We can leave it alone as a benign finding. We can follow it up in 6 months as a probably benign finding, or we'll recommend a biopsy. These are kind of our 3 pathways we can take. Most callback, anything that we call back, about 80% get left alone. That means they either get called benign and no follow-up, or they're going to be followed up in 6 months. I think about 20% on average get put in that biopsy category. And there's 2 different ways we can biopsy. We can either biopsy with stereotactic biopsy, basically a fancy word using a mammogram to biopsy the patient, or do it under ultrasound guidance where we use the ultrasound machine to kind of guide our needle to biopsy. And it's just depending on whichever way we see that best and whatever's easiest and safest for the patient to get to that lesion that we need to get to. If we can't feel that we can get it in a safe way with this minimally invasive procedure, we'll send them to a surgeon for a surgical biopsy.
So, Dr. Patel, in addition to screenings, what's the next step after that?
So after a screening mammogram, the images will go to the radiologist. We'll look at the images. We'll look at the priors, compare the two. If there is nothing new, the patient will be told to return for screening mammogram in a year. Now, when we look at the reason we love our priors so much is we can compare it because that'll really help us know what's different about it and if there is anything new. If there is something new, we will call the patient back for additional imaging, whether that's another mammogram with some dedicated views, special views, or an ultrasound. Possibly both, even a lot of times. There are many times where we might see the abnormality on mammogram, but not the ultrasound, and vice versa. So we like to do both together because they help put the whole picture together for us. And then we'll make a decision based on that, what to do next, based on whether we should let the patient go for the year, have them come back in 6 months, or do a biopsy.
I'd like to remind everybody that on the program today, we have Dr. Patel and Kathy McCarthy. If you'd like to find our program, Mercy Moments, or join the discussion, please go to social media at truechat.org or use one of your local apps, Spotify, Stitcher, or Apple Podcasts. So in our next segment, we'd like to talk a little bit about usage rates and why women are getting or not getting mammograms. Nationally, the average is roughly 65%, give or take, based on the age group. Clark and Champaign County have usage rates that are slightly below that. So next, we're going to talk about some of the reasons why women do not get mammograms. So Kathy, one of the reasons stated that they do not get mammograms is affordability. Can you address that a little bit?
I think there's been a lot of changes over the last couple of years with insurances. There's been laws in the state of Ohio and across the country put in that insurances have to pay for a screening mammogram. There can't be any copays collected, things like that, trying to get this out there for women easier and not make it cost prohibitive for them to get this done. There's also the 3D. When 3D technology came out, it wasn't covered by many insurances. It is now. Majority of insurances are covering it now. So it's always good before you come in to know if your insurance is going to pay for it or not. So you have that expectation. And then there's also, if somebody has trouble with the financial piece of it, there is help available. They can call the centers. They can, there's Financially Blue. There are programs in the communities all over that have been community funded, trying to help women get these exams. There are national programs out there. There are federal programs out there to help with that cost as well. And so what we try to do is get them in the path. What is the best route to take them through so that the majority, more things are covered. So we usually start with the federal programs and work from there.
So the bottom line is if a woman really needs a mammogram or wants a mammogram, she can get one.
Yes.
And on that note, if you don't mind me interrupting, we also take walk-ins, a self-referral. If a patient does not have an ordering physician or somebody that they see routinely, they can come to our facility and get a mammogram because they want one. So it doesn't always have to be, I have to have all this, I have to have the order. I have to have another physician send me here. If she wants one, she can get one, or he.
Right.
That's a good point.
For a screening.
For a screening.
If there's a problem and you feel a lump, you're having pain, you're having any, noticeable skin changes, that becomes a diagnostic, which I think we were going to talk about a little bit. But there is a requirement that there be an order for that from a physician, and know that we have a physician that's going to do the follow-up with you from there.
Correct. Yeah.
So another reason why women say they do not get mammograms is because of the radiation used. So Dr. Patel, can you address that a little bit?
Sure. I'll throw out some numbers here just so you can get a grasp of how much radiation you're getting. The mammogram was a really, really low dose study compared to a lot of your other imaging studies, compared to CAT scans and even certain x-rays. Basically, the conventional 2D mammogram we use millisieverts as our unit to measure radiation. A 2D mammogram was 0.4 millisieverts. That's essentially 7 weeks of background radiation. Chest X-ray is 0.1 millisieverts. With that being said, when we switched to 3D, because of the difference in, you're getting a little bit more radiation, but compared to 0.4, you're getting up to maybe 0.6, 0.7. So it's not significantly more. It's still within the limits that the FDA makes us go below. So you're not getting much more radiation, but you're getting a better quality study with it.
That's a good point.
And that's a combined 2D and a 3D. We've actually kind of taken out the 2D component of that. So you're even getting a little bit less than that at a lot of facilities, actually, with your 3D.
So we've kind of touched on this point earlier in this segment, but another reason why women say they do not get mammograms is because they don't have time. And Mercy in particular has a lot of resources in that regard, Kathy. So can you kind of go over that a little bit with us?
Sure. I think you can separate it into two different things. There's the access points. We have mammography facilities all over the area. We take the mobile unit out. We're out in the communities. We're out at church functions, at public functions, things like that. So getting the mammogram, because of where it's located, I think we've taken care of making sure that it's available in a lot of places. Finding the time, most women are going to be making sure that their children are fed and that they've taken them there and taken them to sports practices and making sure they've taken care of their children, their spouse, their significant others. And we're always the last one we think about taking care of ourselves. And so I think that's where we need to stop. You need to take that time and get that procedure done, take care of yourself and do it for you, because ultimately you're going to do it for everyone you love, because you're going to make sure you're around.
Right.
As everyone, grows older.
And the bottom line is the network has invested a lot of infrastructure in freestanding or in-house mammography units, but we also have a mobile unit with the same capabilities as our in-house units.
Right.
And like you said earlier, they come to multiple locations each week. So
right. And we have the same technologists are out on, no matter which of our facilities you go to, it's the same technologists, the same doctors like Dr. Patel reading the exams. So it's all the same quality. You're getting the same good quality anywhere you go.
And if there's a group out there that thinks we're not addressing them or listening to them, they can always give us a call. And if there's potential there, we can park the mammo there on a given day.
Sure. We do that for businesses. A lot of businesses are letting their female employees take time to go get their mammogram while they're on the clock. They're investing in their employees and doing that. So we set up mobile events at employers. We do it, as I said, with church functions. We go to the county fairs. Anywhere that someone is willing to host an event, we're attempting to get the coach out there.
That's a great point. So another reason why women do not get mammograms is they say that they are painful. So Kathy, can you address that?
Sure. If I could figure out by just looking at a woman which one was going to have no problems with the compression versus someone that it bothers them more, I would be a rich woman because, you just can't tell. And it's not anything about the size of the breast, whether you have a small breast, whether you have a large breast, whether it's medium sized. Some women can have a mammogram every day and it wouldn't faze them a bit. Their breast tissue, it doesn't bother them. Other women, it is uncomfortable. Mine are very uncomfortable. I know the technologists that are doing it. I know what they're doing. I know they're doing it right, but mine are uncomfortable. And so you just can't tell whether it's going to bother someone or not. But majority, I would say the 98% of the women that come in and have it done say, that was it? Really? I've heard all of this about how painful it is and that, and they leave and they go, that was nothing. So, you just don't go around saying, hey, I had a great mammogram today. you don't do that. But it's not something we don't want to take the time. And so we talk about it as though it is the worst thing you can have all year. Right.
And to go along with that, the reason you need the compression is more for us. When we read these mammograms, we want to spread out that tissue. We want to stop the tissue from moving. And that's why that compression is really important, and to do a good compression, because that's how we're going to see anything hidden that's in there, any masses that are hiding, and the less motion, the better compression. It makes for a better exam for us to read.
Right.
And it also reduces the radiation because the thickness of the breast determines how much radiation we have to use.
And in that vein, women say that another reason why they don't get a mammo is because they're afraid of the findings. So, Dr. Patel, can you kind of discuss the advantages of early detection in regards to breast cancer?
We understand that this is an anxious process for most women, that waiting for that call back, whether it's, you got to come back or you're not, we understand that. The idea is, in most like the American Cancer Society, Society of Breast Imaging, that anxiety, the thought of having cancer beats out the anxiety essentially. And that's why we do these routine mammograms. So even if you do have a finding that needs to be worked up, let's say we call you back for something, by far majority of the time, it's going to be benign. I think I mentioned earlier about 80% of them tend to be benign, which either require no follow-up or a 6-month follow-up. So not every time you get called back is it going to be a cancer, but you get called back because we want to make sure it's not a cancer. And and we mentioned earlier, the earlier things are detected, hopefully the better outcome in the end for the patient.
Right, that's a good point. So even if we do find something, if it's caught early, I believe the statistic is 99% of all early detected breast cancers are treatable. So that's a good point. So whether we find something or not find something, it's good to have or catch something early. The last point is that a lot of women believe that mammograms are only for older women. So Dr. Patel, could you address that a little bit?
Mammograms are not just for older women. In fact, the earlier these are detected, the better overall outcome you can have. But the idea is some of the earlier breast cancers, especially in the 40 age group, tend to have more of a mortality, I think, associated with them. The younger the patient is, they have a higher mortality. And it's been shown that when they do catch it, it really, overall, their mortality decreases. And especially in that younger age group. I mean, the older we get, we do become more at risk just because, with age, like everything, I feel like you're more at risk for things. And just to go back to mammogram, it's not a perfect imaging modality. We will miss cancers. It will detect most, but there are times where we do miss things. It's like I said, it's not a perfect thing, but it is an overall useful tool overall to find breast cancer.
It's the best thing we have available to us right now, currently, yes.
Right. And we wanted, the biggest thing with that too is it can't be just a mammogram. You can't just say I have a mammogram once a year, so I'm okay. It's your, routine mammograms. It is your healthcare provider seeing them once a year, them doing an exam and checking in with you. And then ourselves having breast awareness. What do I normally feel like? Because it's important that we don't expect patients to know what's good or bad. What we want to know from them is what's new and different for them.
There are so many patients who come in because they can feel it. They will find their own breast cancers.
Right.
And the reason back to, getting those routine mammograms, doing these routine checkups, there have been recommendations out there in the recent past few years that recommend them every 2 years. And oftentimes you will miss, there's been statistics up to 30% of cancers in that time, in that 2-year range. So that's why we still recommend the yearly mammogram. And just to remind everybody, overall statistics, breast cancer, 1 out of 8 women in their lifetime. That's still the estimate for patients to get cancer. And we didn't really touch on this, but, there is a discrepancy between minorities. African-American women have a higher mortality rate, which should be recognized and even, considered more, get into screen.
Right.
You do have a higher mortality associated with that. So there are different risk factors that you should be aware of, and that's something to have a discussion with your provider about.
Right.
So just to sum up, we encourage you to get your yearly mammogram. Mercy has multiple resources available to you in the community to get a mammogram. So there really isn't any reason not to get one. I want to remind everyone that you can listen to True Chat Podcast on Spotify, Apple Podcasts, Stitcher, or where any fine podcasts are found. And if you have any more questions about mammography, you can find answers to them on mercy.com. For Mercy Moments, I'm Terry Sealer.
Kathy McCarthy.
Deepika Patel.
See you next time.